Okay, today we're going to start Chapter 3, our chapter on urinalysis. This week we're only going to cover slides 1 through 58, which is learning about where urine is produced, along with the things that we look at when we do a urinalysis. In week 6, we're going to move a little bit more into the microscopic parts and pieces of the urinalysis that we do. All right, looking at the anatomy and physiology of the urinary system, it has a few functions. First, it removes any unwanted waste from the body. It also stabilizes our blood volume, acidity, and electrolytes. It regulates our extracellular fluids of the body. And some things that people didn't realize is it secretes hormones. Did you know that erythropoietin, sometimes it's called EPO, can actually pick up some of the oxygen content of the blood and cause the body to make more red blood cells as those things are passing through the kidney. And also renin. So if your blood pressure drops, your kidney has the ability to secrete renin, which will make you retain more sodium, which will increase your blood pressure. It also regulates the absorption of calcium ions by activating vitamin D. So a lot of people have had a vitamin D test, especially sitting in the middle of, cold, cruddy weather that we have right now. Nobody's really being exposed to the sun. You need the sun to make vitamin D. But what people don't realize as well is you also need your liver to convert some of that vitamin D, and then your kidneys to work to convert the vitamin D to an activated form that actually allows you to absorb more calcium and builds bone and use it for neuromuscular contraction. Here are some structures of the urinary system. Well, the kidneys are this reddish brown bean shaped, literally looks like a kidney bean, 4 to 5 inches long, which is located slightly above the waistline in the back or posterior wall of your abdominal cavity. We call it the retroperineal position. Each kidney has a ureter that carries the urine down to the bladder, and then the urine is expelled via the urethra. Some students struggle with the difference between the ureter and the urethra. Like, oh man, I get those confused. Well, a teacher once told me that you have 2 ureters, but Urethra Franklin, she's the one. So if you think of like Aretha Franklin, if you know who that is, Urethra Franklin, she's the one. That is the one tube that comes out the body. All right, different sections of the kidney. The kidney is divided into different layers per se. The first one, the adrenal cortex, is the outer area, which is the outside of the kidney, consists of arterioles that carry the blood to the glomeruli, which filter the waste from the blood to the urine. So that's where the blood travels first. The renal medulla is kind of the middle region. Medulla sounds like middle, right? That's the inner region of the kidney that processes and transports the urine to the renal pelvis, which is the middle. The renal pelvis is the hollow funnel-shaped area, as you can see over here, that draws the urine out towards the ureter to the bladder and then out the urethra. Then we have a deeper dive into the kidney, the renal corpuscle. The glomerulus is made of tangled blood capillaries. So as the blood comes in, it goes into these little tiny capillaries and these little tufts, as you can see here. Okay, they look like reminds me of the little shoestring licorice that we used to eat as a kid. So it's tangled blood capillaries, which are, they're pushed through. The blood is pushed through pores in the capillaries and into the Bowman's capsule. The Bowman's capsule, as you can see, is this little, actually it's bigger up here. It looks like a little U shape here around around that capillary bed. The plasma will actually travel across that membrane into the Bowman's capsule. Now, cells and protein cannot make it through that. Those are things that we need to hang on to in our body. We don't want to pee out all of our cells and our protein, right? We want to keep that. So hydrostatic pressure puts the waste products and the water through, but it keeps the cells and protein from going through. This is connected to the whole entire nephron. So you can see we got the Bowman's capsule here. The blood comes in. We got the Bowman's capsule here at the beginning. Then that filtrate that made it through goes through this complex process of going through these tubules. Okay. There's approximately 1 million of these in each kidney. So the first thing that happens is it comes through this Bowman's capsule. It heads to the proximal convoluted tubule, which is in the closest proximity to the Bowman's capsule. So that's how I memorized that one. We have this nephron loop, sometimes called the loop of Henle. You can see it goes loops all the way down and all the way back up. Then we have the distal convoluted tubule, which is in the furthest distance from the Bowman's capsule, followed by the collecting duct, which is the final concentrating site, which will then head to that renal pelvis, the ureter, and then the bladder. So we just discussed these, so I'm not going to go over these in much detail, but we'll just talk about some areas we didn't talk about. The ureters are quite long. They're 10 to 12 inches long, and they carry the urine to the bladder. The bladder is a hollow muscular organ that holds urine until it's expelled. Another term for that is micturition. The urethra is that one tube that carries urine outside the body. And the interesting fact here, in males, that tube is 8 inches long. In females, it's only 1.5 inches. The urethral meatus is the external opening from which the urine is expelled from the body. So we got 3 steps in the formation and flow of urine. First one is filtration. Filtration is where fluids and dissolved substances, based on their size, and waste products especially, are forced through the glomerulus into the glomerular capsule by hydrostatic pressure, creating a liquid called that glomerular filtrate. It's very similar in the makeup as your plasma is in your body, but it doesn't have large proteins and cells. The next step is reabsorption. So as your as that filtrate starts to travel through these tubules, things that your body needs are reabsorbed back into the blood. Okay, so examples are glucose. We shouldn't have any glucose in our urine. Glucose is blood sugar. Your nephron has the ability to push glucose back into the bloodstream until your blood levels are between 160 and 180 milligrams per deciliter. Now, us, people that are non-diabetics walking around usually have a blood sugar between 70 and 110. If you're a diabetic, it's not uncommon on occasion for your blood sugar to get up to 160 or 180 or higher. And when that does happen, your kidneys cannot push that much back into the blood. So then we start seeing sugar in the urine. Okay. The next thing that it does is secretion. So some substances are transported from the capillaries into the renal tubules. Many metabolites from drugs enter the urine at this point, but also sometimes we need more things in the bloodstream. We may need more sodium. We may need more chloride. We may need more bicarb. So these are things that if your body is deficient, the kidneys are able to pick that up and push those things from that urine back into the bloodstream. If there's too much, it's able to pull it out, so it regulates that balance in the body. So here's a little bit of the review of how this thing works. So you have the bloodstream with the waste products. Blood enters the kidney via the afferent arterioles. It goes through the glomerulus into that Bowman's capsule. Okay, remember the glomerular filtrate is what makes it through. We have renal tubules that they travel through, the collecting ducts. We got the renal pelvis, the ureter, the urinary bladder. Remember urethra Franklin, she's the one. And then urine is expelled from the urethral meatus. That is the order of things as they travel through. So next we're going to talk about what is in urine, what is it made of? Can we really drink it? And I know you guys have seen maybe Facebook videos or Instagram videos of people drinking their own urine, and it makes you wonder, is this actually safe? Well, actually, yeah, it is, because water makes up 95% of the substances in urine. Any additional waste that you might be ingesting, your body will actually just re-secrete. So I would imagine over time, you could only do this so many times, but it would probably get you through a period of time where you don't have water. So I know, gross thought. But urine also contains waste products like urea, uric acid, ammonia, and creatinine. All of those are excreted on a regular basis. You will always have those in your urine. Where urea, uric acid, and ammonia are derived from the breakdown of proteins. So after you eat your filet mignon, your body will use up that protein, but after it's used up, it breaks down into those parts. Creatinine is a waste product of muscle metabolism as well. Other waste products include chloride, sodium, potassium, calcium, magnesium, phosphate, sulfate, and some of those you can call a waste product, but those can be reabsorbed back into the body as needed. So every day, the average person has approximately 1,200 mLs of blood pass through the renal arteries per minute with a daily output of about 1,200 mLs of urine per day. That is equivalent to about 3 soda cans. Obviously, this can vary depending on the amount of intake of fluids and the amount lost from perspiration, feces, water vapor from the lungs, etc. Now, this is just an average. I mean, if you are an avid water drinker like me, it would not be uncommon to produce over 2,000 mLs a day. If you don't drink anything, and I've seen some people that barely drink a glass of water a day, obviously they're not going to produce this much. So some of the terms related to urination that you need to be familiar with. Diuresis is the increased volume of urine output. Anuria is no urine flow. This could be from maybe renal failure or some type of a blockage. Dysuria is painful urination, as in like maybe a urinary tract infection. Nocturia is excess urination at night. Oliguria is decreased urine volume, just not having very much, usually less than a soda can, but more than 100 mLs. Polyuria is passing abnormally large amounts of urine, greater than 2,000 mLs a day. And when you think of what's 2,000 mLs, Becky? Well, that is a 2-liter bottle of soda. So if you think of those giant bottles of soda you can get at the grocery store, that's 2,000 mLs. All right, so how do we collect this? We have a bunch of different collection methods. The volume needed to do a urine test is usually between 25 and 50 mLs. We need to clean the outside of filled container cups. We clean the outside of filled container cups with a disinfectant. Now this, as long as you're wearing gloves, you really don't need to disinfect it too much. Label it correctly on the container, not the lid. Okay, it has to go on the side. Has to have our standard patient identification information on it. Infant collection bags must have adhesive openings that surround the genitals, but not the anus, because we don't want to get feces inside. I have a picture of one of those right here. It's very difficult to get a urine specimen from a baby. So what they do is this yellow part right here is sticky, and they stick that to the baby's genitals. Preferably if you're, an MA one day and you're having to draw blood from a baby, and the doctor orders a blood draw and a urine sample, put this on the baby before you draw the blood, because I guarantee you they will go while you're drawing their blood and they're screaming their head off. Works well. If the urine's being collected for microbiology studies called a culture, we have to use a sterile urine container because we don't want any bacteria from the environment contaminating that. So a couple things to remember: postpone if the female is menstruating. If the urine must be tested, note that on the requisition so that the physician is aware that the blood in the urine is not from an infection. Test urine as soon as possible or within an hour of collection. Refrigerate it if it's going to be longer than an hour. Collection method depends on the tests that are ordered, and we'll talk about a couple of these. The first type of specimen is a random specimen. We collect, in most cases, ideally, the midstream portion of the urine when voiding. So first, they void in the toilet. Then they put the urine cup under the stream. They collect the second part, and the rest goes into the toilet. The reason for this is it flushes any areas of the outside of the body to make sure we don't have contamination with bacteria or skin cells that could potentially be sitting at the outside of that urinary opening. By flushing that with the first stream, we get a nice clean specimen, and when we're looking at it under the microscope, it makes a big difference. And when we get to the microscopic part of urine, we'll have you guys probably do both so that you can see the difference. All right, the next one is a first morning specimen. This one is usually pretty ideal as it's the most concentrated. If they're looking for some type of a metabolic abnormality, usually this will pick it up because it is more concentrated. You get up and go to the bathroom the first thing in the morning, your urine's more dark yellow. That means there's more stuff in it for us to test. It's formed over an 8-hour period, so it's been sitting in your body for that long, and the volume is usually at least 25 mLs, if not a lot more. The clean catch midstream we just talked about. So that is cleaning the body with a towelette and doing the midstream that we talked about a few slides ago. There are some behavioral criteria when working with these patients. So note that the 4 steps involved show awareness of a patient's concerns related to a procedure. So we need to gather the supplies and review the patient's history, correctly prepare the patient, respond to patient concerns, and demonstrate professional behavior and exhibit appropriate conduct. So when we are talking to a patient about their urine collection, okay, we need to make sure we understand what type of collection the physician wants. Do they want a first morning? Do they want a midstream clean catch? Do they want one to be taken after they've eaten? Do they want one of the nurses to collect it via catheter? So those are things we have to be aware of. Also, the patient may, if the doctor does order a catheterized specimen where they have to put a tube in the bladder, you have to talk to the patient in a professional manner about that process. They may not understand it. We have to talk very professionally and be very empathetic with them on the process that they're about to go through. So here's an example, a timed urine specimen. Some patients may have to collect a urine for 24 hours. When a 24-hour specimen needs to be collected, it means there's probably pretty concerned about something pretty serious going on with this patient. The patient will need to collect all of their urine for 24 hours in a large container. So this will require some very detailed instructions to the patient. The preservatives and refrigeration are often for timed samples. You're going to have to check with the laboratory if you're not sure to know what type of preservatives should be used. If you don't do that, there is a chance that if it's not collected correctly, the lab will reject it and the patient has to recollect a urine for 24 hours. That's not a very popular process with the patient to begin with, and to have to do it twice is very undesirable for them. Sometimes as well, which I should have mentioned in the last slide, we put acid in those containers, concentrated acetic acid. So it's very important that they don't urinate into the jug because it could splash back onto them. So those are some things that you want to make sure the patient understands if in fact there is acid in the container. So with a 24-hour time collection, the first morning specimen is discarded. So they get up, they go to the bathroom, and then they start a timer right after. They empty their bladder for 24 hours straight and put the specimens into the container. The last specimen is kept. So if they start at 8 a.m., okay, they go to the bathroom at 8 a.m., then they start the timer. They keep doing this until the next day. They get the last specimen. They go one more time at 8 o'clock in the morning, and that is their last sample. The reason why they collect that last sample is because that urine was produced in their body during that 24-hour time frame. Then we need to prep the sample for transportation. So usually refrigeration is most common, but if it's something that's not a creatinine, you're going to want to check because you don't want to mess that up. All right, so now we're going to talk about the actual CLIA wave testing for urinalysis. This is a very common test. It's very simple. We are going to be performing this, so we're going to go through a rundown of what all of these things mean before we actually do it. All right, so urinalysis is considered a CLIA wave test. Now we can do, as medical assistants, the dip on the urine and report that. When it comes to the microscopic piece of the urine testing, which is using the microscope, we're going to be preparing samples for that, but this isn't something that you would be reporting. That would be considered a moderately complex type of testing that would be done by a medical laboratorian. All right, so here are some things you might see on the requisition form for the urine. So you receive a requisition. It's probably going to have a couple different things. It's going to be routine, microscopic, and quantitative. Those are a couple different types of tests that we might see. Routine is just a typical dip that gives you a printout of the different chemicals that are in the urine. The microscopic is where we look at it in the microscope, and quantitative would refer to something like the 24-hour urine collection. All right. The microscope test is the advanced concepts. We're going to talk about that after slide 58. We'll do that week 6. The quantitative column would be used with a 24-hour urine, so I just talked about that. All right, so let's talk about this routine urinalysis. The physical part of the urinalysis consists of the color, the odor, believe it or not, and the appearance or transparency of a urine color. A normal color is what you see here. It's straw, which is light yellow to kind of a dark yellow. So that's kind of a synonym for that. What makes urine yellow is urochrome. That is a chemical component that makes it yellow. That's important to know. Some abnormal colors that we see is yellow-brown. That could mean excess bilirubin. Orangish yellow could mean urobilinogen. Don't worry, we're going to talk about what these are in a minute. Green could be biliverdin. Okay, so that's oxidation of bilirubin. It could turn dark red from red cells. Dark red-brown from having red cells or myoglobin. I think I talked about in class the rhabdomyolysis that those patients get that were in the prison that were lifting all those weights and their urine looked like root beer. That's from a lot of myoglobin. Myoglobin comes from the muscles, so that breakdown product. Clear red could mean that there's hemoglobin. It's not abnormal sometimes to have blood in the urine and the urine is so concentrated or not concentrated and it causes the red cells to burst and it kind of looks like a clear red color. Cloudy red means there's actual blood cells in it. Once those cells burst, then it becomes clear. So there's a lot of things that can cause a clear red urine. All right, so talking about the odor. Odor is important. And there's a lot of times where you smell something and you're like, oh, that's just not right. The first one is ammonia. Ammonia comes from the splitting of urea. Usually this is from an old urine. I've seen this come from, more so if I'm working in a laboratory and a urine comes from a site far away where it had come in with a courier, like maybe a nursing home out of town, and it sat overnight, and then it sat in the courier's car, and it makes it to the lab. This old urine will start to smell like ammonia over time. And to give you any indication of what this might smell like, have you guys ever, and I unfortunately have smelled this, if you have a cabin up north or if in your own bathroom, somebody used the bathroom, and if you have kids, this has probably happened. You leave for the weekend and come back, the smell of that urine in the toilet will knock you over. That's ammonia. Sweet or fruity could mean ketones or sugar, blood sugar. Foul smelling could mean the decomposition of leukocytes or having a urinary tract infection. And if it's musty, it could mean PKU, which is phenylketonuria. Not going to get into a lot of detail on that, but it's a type of a metabolic disorder that people could have. So first we'll talk, or after the odor, we'll talk about the appearance. Most urine is clear or slightly cloudy. If there's something wrong with it, it could become cloudy or turbid. So these are very descriptive terms that are very important. You can't use a different term. These are what we're held to. So a fresh urine specimen should be clear. As urine sits, it can become cloudy due to the formation of some normal crystals, but it can also be cloudy from bacteria, yeast, cells, casts, mucus, sperm. There's a number of things. So as you can see with these urines that we have here, the clear one, you can see a newspaper through it. Slightly cloudy, you can just barely make it out. Cloudy, you can tell there's words there, but there's but barely. Turbid, you cannot see any words at all. So when we describe what the urine looks like to the physician, these are the terms that we use. Now for the chemical urinalysis, we use reagent strips, okay, and we'll see a picture of this in a little bit. The strips contain 10 colored squares. Each colored square reacts with a specific analyte in the urine if it's present. So the supplies, here, let me just get a picture here. You can see the reagent strips down here underneath this vial. Normally we don't put them underneath the vial like that. But we dip that dipstick, kind of like when you dip your oil in your car, into the urine, and each of those little pads of color will turn a different color. We can compare that to the grid on the side of the bottle, and it will tell us exactly how much of that chemical or analyte is in the urine. So it detects analytes semi-quantitatively. Qualitative is positive or negative. Quantitative gives an exact number, and qualitative determines an approximate quantity. So it's not exact, okay? These reagent strips are time dependent, so we have to use a timer to time them while we're doing the testing. All right, so the reagent strip bottle must be kept tightly closed. Those pads on that strip cannot be exposed to any moisture or it will start a chemical reaction within that strip. We don't want that to happen. Don't refrigerate them. We keep them in a cool, dry place, usually in a cupboard. Check the expiration date. Okay. If within the expiration date but opened longer than 2 months, they need to be discarded. Do not combine strips from different bottles. We need to mix the urine well. Make sure all pads are covered with the specimen. Do not leave a strip in the urine too long. Okay, so don't just dip it and let it sit there. When taking the strip out of the urine, remove excess by gently pulling back the strip along the side of the container and blotting it on absorbent paper. Hold the wet strips horizontally to keep the reagents from running into each other. There's a video after this video that I want you to watch showing this process. We use the color chart on the side to interpret the results from each analyte. We start at the top of the strip and move upward. Plastic charts are available from the manufacturer that can be cleaned as well if needed. We don't have those. Good idea though. With these strips, we always have to run quality control. We'll have some quality control bottles that look very similar to this. We run the controls the same as patient specimens and compare the results to the manufacturer's ranges. So level 1 would be normal, and level 2 is usually abnormal. This tells us that the test strips are actually working. Another way that we do this, which is a lot easier, I'm going to have you guys do it manually first so it really gives you an appreciation for the automated method. It automatically reads the reagent strips. So timing and color interpretation are consistent, but when the urine has large amounts of pigments, it may produce a false positive. An example is a medication people take called, sometimes it's called azo or phenazopyridine. It makes your urine turn bright, bright, bright orange. And that makes every single strip on the urine turn orange. So in that case, almost everything is inaccurate with the dipstick. We have to kind of go off of what the microscopic says. So let's talk about some of these little pads on these test strips and see what they actually test for. One of them is specific gravity. Specific gravity is the weight of urine as compared to an actual volume of water. Water has a specific gravity of 1.000. Your urine does have dissolved substances or solutes in it. It's going to have urea, that's pretty heavy. It's going to have salt, it's going to have all kinds of things in it. So the normal range is 1.003 to 1.030. So that means that the body pulls water back out of it and it adds, you'll have some waste products in it. The next one is pH. This measures the amount of acidity or alkalinity in the urine. pH of 7 is neutral. A pH of 0 to 6 is acid, and 8 to 14 is alkaline. The lungs and kidneys are responsible for maintaining the body's acid-base balance. So the kidneys do a little bit of it, but lungs do quite a bit when it comes to acid. The blood pH must be in range of 7.35 to 7.45. A normal urine pH is 5.0 to 8.0. Most patients have a pH of 6.0. Your body has the ability to buffer the blood and keep the blood at the 7.4 range, which is right in the middle, by causing the pH to be a little bit lower of the urine. We want to make sure we use a freshly voided urine because bacteria will cause the pH to increase. Definitely a fresh urine. Glucose is the next one. We always test for glucose, and in most patients, it's negative. So other things that it might test for, lactose, fructose, galactose, pentose, those a lot of times are not tested for in these dipsticks, but those are also sugars. The enzymatic reaction on the strip is testing for just glucose. It uses an enzyme called glucose oxidase to look for glucose. If somebody does have glucose, it could indicate diabetes, strenuous exercise, or stress. False positives can occur with large amounts of ascorbic acid, which is vitamin C, or aspirin. So if a patient is a pediatric patient, sometimes they want to look for other sugars besides glucose. So they may order what's called a clinitest. A clinitest may be used to detect galactosemia in children. This can cause, it's a metabolic issue that can cause problems. And usually we pick it up in kids because I think it causes a lot of problems later on in life. So they may check to screen to see if this could be a problem. Lactose can be found in the urine of pregnant women. In rare instances, fructose and pentose can be found because of high consumptions of honey or fruit as well. I haven't really come across that too much in my day, but I guess it is a possibility. The next are ketones. Everybody's on the keto diet right now, right? So what the heck is that? Well, these are products of fat metabolism. So the theory behind the keto diet is that you eat most of your calories come from fat. Your body normally uses carbohydrates for energy. It can also convert excess protein to carbohydrates for energy. But if you deprive your body of carbohydrates and protein and only eat fat, your body will metabolize the fat on your body first. When that happens, the breakdown products of fat metabolism are ketones. Kind of like the breakdown products of protein or amino acids, we will pick these up in the urine. People that typically have high ketone levels are diabetics because they are unable to use their carbohydrates, so their body starts burning fat as an energy source. And people that are on this keto diet or Atkins diet who have deprived themselves of the other two major macronutrients of carbohydrates and proteins. All right, so ketones, if a diabetic patient comes in and they have positive ketones, they test the patient to see if they're in ketoacidosis. That is a dangerous situation in a diabetic. Now, if somebody's on the keto diet and they're not diabetic, they're not going to go into ketoacidosis. This is specific to diabetics, okay? Again, we have the other things that we may see this in: ketones without glucose, anorexia and starvation, low-carb diets, hence the keto diet, excess vomiting, and fever. A confirmatory test that we can do is called the acid test, which involves a little tablet that we add urine to. Bilirubin is next. This one enters the liver where it becomes water soluble. Okay, sometimes your liver isn't working, so it's not able to make it water soluble. So we end up with this greasy yellow bilirubin floating around the bloodstream. You can see it in the skin. They kind of turn yellow. They have jaundice. Their eyes kind of turn yellow. And they'll have a very dark yellow, almost amber colored urine as well. Here's what the urine from a patient who has a high bilirubin might look like. We can see it in the whites of the eyes as well. The confirmatory test for this is icto test. The next one is urobilinogen. I know there's a lot of tests on these strips, right? It's amazing what you can tell from a person from just a little urine. So it's normal to find small amounts of urobilinogen in the urine. What this is the breakdown of bilirubin in the intestines by bacteria. So in your body, your red blood cells only live 120 days. Those die after 120 days. Your body, and one of the parts of them is bilirubin. This bilirubin then goes to the liver, which slides down, becomes conjugated. It slides down the biliary duct into the intestines and is converted to urobilinogen and then to urobilin. Well, that urobilinogen is actually reabsorbed from the intestines and through the kidneys. Some of it remains and turns into urobilin, which makes feces brown. Some of the things that can make urobilinogen abnormal are hemolytic diseases. That means that red cells are bursting in the bloodstream for a variety of reasons. Nothing that we're going to get into. Having hepatic disease, okay, so if you have liver disease, hepatitis, it could be increased. Or biliary obstruction. This would cause the urobilinogen to be almost absent. The next thing we test for is blood. Blood in the urine is called hematuria. This can be from bleeding in the urinary tract caused by renal disorders such as stones, tumors, lesions, cystitis, and urethritis. 3 substances that can cause the pad to be positive for blood: intact red blood cells, hemolyzed red blood cells, which means they've popped, and myoglobin, which is a substance like hemoglobin that transports oxygen in muscle and tissue. Hemoglobinuria can be caused by transfusion reactions, malaria, drug reactions, snake bites, and severe burns as well. The next one is protein. I talked about this with the Bowman's capsule and the glomerulus. Protein should not make it into the urine, okay? Small amounts are normal, it says. It would have to be very, very, very small amounts. In most cases, the protein on the dipstick should be negative. The only reason it might be positive and be normal is extreme strenuous exercise. It would then go back to normal later in the day. Okay. Proteinuria can mean renal disease. So some protein in the urine is temporary. Like I said, fever, cold, exercise, emotional stress. All right, another test that we do, this one is not part of the dipsticks that we're going to be using, but there are additional dipsticks or tests that are done in the chemistry department for microalbumin. This determines if small amounts of albumin are excreted. So we do these on almost all diabetic patients once or twice a year, and this picks up minute or micro amounts of albumin in the urine. So we go and we really take a close dive, because if we can find small amounts of protein in a diabetic's urine, we can try and educate that patient on better following their diabetic regimen a little bit better before it becomes dangerous to their kidneys. If you wait till you have massive amounts of protein going through the kidney, it may be irreversible, and that patient may really struggle with end-stage renal disease. Now, if you pick it up very early on in very small amounts, you can educate that patient. So you want to pick up that protein early, not wait till it's too late. Sometimes they do a microalbumin and creatinine ratio. So this tests for the creatinine, which is a regular waste product, and to see if microalbumin is passing through. The ratio should be less than 3.4, but levels between 3.4 and 33.9 indicate microalbuminuria. It's essential for diabetes, looking at hypertension, which is high blood pressure, heart attack, stroke, pregnancy. We want to make sure that the kidneys are healthy in pregnancy too. The next one is a Bence-Jones protein test. This is a type of protein that coagulates between 45 and 55 degrees, and it redissolves when you boil it. That's typically not the main way that we test for that anymore, but that's kind of the old gold standard. This can be used to detect multiple myeloma. Multiple myeloma is kind of a cancerous situation where the body makes boatloads of abnormal proteins, and it can really gum up your body, for lack of better words. You have these types of lymphocytes that just produce tons and tons of abnormal proteins. That's multiple myeloma. All right, the next one is nitrates. So in the urine, this can be caused by bacteria. So not all bacteria convert nitrates to nitrites. Okay, first morning specimen is usually best, but in a lot of times a patient coming to the emergency room or the clinic with a urinary tract infection's gonna not have waited overnight, right? So if this is positive, they usually do a urine culture. E. coli is the most common cause of UTIs, and that one does have a positive nitrite test. All right, one of the last ones here is leukocytes. These are white blood cells. So if you do have white blood cells in your urine, it's usually indicative of an infection like a UTI or a kidney infection. When they're lysed, they release esterase, so you could have a leukocyte esterase, which is what the reagent is in the test strip. All right, so coming across one of our last ones here, becoming proficient at urinalysis. Notice all physical and chemical tests are listed with a reference range on them. Results are recorded next to the reference column and checked for any results, to make sure. And you'll be performing the physical and chemical tests on urines in lab. We'll also be recording those results on a form, which is also in your workbook. Okay, so this is what we're going to perform in class at the beginning of next week. Make sure that you are aware of the testing process, because we're going to go through that pretty quickly before we go ahead and start this. Also be sure to answer the 5 questions after this video to make sure you get credit for that.